I think this afternoon, the final session, we have a lot of things to think about. So initially we have tynapenia, pre-sarcopenia, possible sarcopenia, and sarcopenia. And the second one, we have frailty. And right now we have osteosarcopenic obesity. And last one, we have osteoporosis. So our last speaker is Dr. Shaohuai Fu. He is from Yunlin branch of National Taiwan University Hospital. He's right now assistant professor of our National Taiwan University School of Medicine. And also he the study is sponsored by the National Center of Geriatrics and Welfare Research. He did a lot of publication in osteoporosis. So let's welcome him for this final talk. The talk is about unlocking a novel anabolic effect, synergistic benefit of sequential strong anti-resorptive osteoporosis medication. Let's welcome Dr. Fu.
Thank you. Thank you, Professor Chen. And good day, distinguished audience. I'm Shaohuai Fu from National Taiwan University, Yunlin Hospital. And I'm honored to be here with you today. I'm delighted to present our research on denosumab sequential therapy. And I will discuss the potential synergistic benefits of sequential strong anti-resorptive osteoporosis medications. So osteoporosis imposes a significant disease burden when accessed through the disability-adjusted life year, ranking closely behind lung cancer in terms of its impact on overall health. The high death associated with osteoporosis underscores the substantial health challenges and diminished quality of life experienced by individuals affected by this bone-weakening disease. So addressing osteoporosis is very important. Fortunately, after years of development, there are now numerous medications, and most of them have a great reduction risk of osteoporotic fracture by 30 to 70%. So we have many weapons. Among older anti-osteoporosis medications, the top performers in preventing fractures are teriparatide, romosozumab, denosumab, and zoledronate. These medications can prevent more than 60% of spine fractures. The first two are bone-forming medications, while the later two belong to anti-resorptive class. The three most well-known bone-forming medications are romosozumab, teriparatide, and abaloparatide. Romosozumab is an anti-sclerostin antibody with dual effect, promoting both bone modeling and inhibiting bone remodeling. Teriparatide and abaloparatide are both parathyroid hormone-related protein analogs, stimulating osteoblasts and fostering bone formation. And regardless of whether abaloparatide or teriparatide is used, both can significantly increase spine bone mineral density with annual increase of 8 to 10%. In contrast, romosozumab can increase spine bone density by as much as 13.3% in 1 year. The treatment of postmenopausal women with osteoporosis using teriparatide led to significant increase in cancerous bone volume and connectivity. It also resulted in improved trabecular morphology, favoring a shift toward a more plate-like structure and an increase in cortical bone thickness. These alternations in cancerous bone and cortical bone morphology are both benefit to our bone and also prevent the fracture risk. This figure illustrates the anabolic window associated with various anabolic agents, defined as the interval between the bone formation marker, P1NP, and the bone resorption marker, CTX. Teriparatide and abaloparatide are approved for 24 months, that means 2 years treatment duration, whereas romosozumab only approved for 12 months treatment period, partially reflecting the difference in their anabolic window periods. So although they are very strong anabolic drugs, but they cannot be used too long, only for 1 year or for 2 years. Denosumab is an antibody here to inhibit the receptor activator of nuclear factor kappa B ligand, RANKL ligand, and bisphosphonate, nitrogen-containing bisphosphonate stop osteoclasts from sticking to the bone by blocking a key enzyme and inhibit bone resorption. As we all know, denosumab and bisphosphonate have different mechanisms of action, and their half-lives in the body vary considerably. These factors have a profound impact on their residual effect after drug cessation, and we will discuss later. Throughout denosumab treatment, there was a consistent and persistent increase in bone mineral density, particularly in the lumbar spine, with no apparent plateau. After 10 years of treatment, lumbar spine bone mineral density can increase by up to 21.7%. However, after stopping denosumab, there is a rapid increase in bone resorption marker here, CTX, the green line, and above the baseline, which remains elevated for up to 2 years and result in a rapid bone loss in lumbar spine within 1 year. This is known as the rebound effect. After stopping alendronate, the blue line, CTX remains suppressed for 2 years, and lumbar spine bone mineral density remain above the pretreatment level for 2 years. So previously, we conducted a population-based cohort study published in the Journal of Internal Medicine to compare the risk of major osteoporotic fracture, vertebral fracture, and non-vertebral fracture among patients who had discontinued anti-osteoporosis medication. Our study revealed that discontinuing denosumab led to a heightened risk of major osteoporotic fractures, particularly vertebral fractures, and this elevated risk typically became apparent within 1 year after discontinuation and increased with longer treatment duration. For instance, here, after 1 year of denosumab treatment and stopped drugs, the major osteoporotic fracture risk would increase about 60% when compared to continued user of denosumab. And the vertebral fracture risk will increase to about 118%. And after using denosumab for 2 years, and we could see that the risk increased a lot, and the vertebral fracture risk will increase to about 258%. On the other hand, about the bisphosphonate who used for 1 year and stop, or who used for 2 years and stop, we could see that the fracture risk, although would increase a little, but also less than denosumab. So a recent review article in The Lancet cited our work and recommended not delaying the denosumab dose by more than 1 month. Bisphosphonates, including alendronate and zoledronate, lead to gradual improvements in lumbar spine bone mineral density, although the increase is less pronounced compared to denosumab. Additionally, the total hip bone mineral density tends to reach a plateau approximately 3 to 5 years after the initiation of treatment. And osteoporosis medications have rare but serious side effects. 2 notable rare side effects associated with some osteoporosis medication are a medication-related osteonecrosis of jaw and atypical femur fracture. And the occurrence of these side effects may rise with prolonged use, prompting recommendations for a drug holiday in patients undergoing extended bisphosphonate treatment. But drug holiday was not suggested in denosumab because we know it would cause a rebound effect to cause more vertebral fracture. So the summary of drawbacks of anti-osteoporosis medications, we could see that about anabolic anti-osteoporosis medications come with notably higher costs of treatment and making them financially burdensome for many patients. Additionally, these medications are typically suitable for only 1 to 2 years, only for short-term use, limiting their long-term efficacy in managing osteoporosis. And about anti-resorptive agents also have certain drawbacks, such as rare but concerning side effects like osteonecrosis of jaw and atypical femur fracture. And about denosumab, we could see that after stopping denosumab, it could cause a rebound effect, large bone mineral density loss, and fractures. About bisphosphonate, bisphosphonate was less effective in increasing bone mineral density and would have bone mineral density plateau after treatment for 3 to 5 years. So also the same review in the Lancet recommends investigating the effectiveness of various treatment sequences, including the incorporation of cycles with this sequence. So as Professor McClone emphasized, the management of osteoporosis necessitates lifelong attention, and the optimal approach should be personalized, often involving the sequential utilization of various classes of osteoporosis medication. He also personally recommended to use zoledronate toward the conclusion of the treatment cycle due to its extended duration of drug effect. So he also suggested a structured treatment regimen, proposing the initial use of estrogen to prevent menopausal bone loss and preserve trabecular microarchitecture. Following this, he recommended a 3-year intermittent alendronate therapy with a drug holiday of 1 to 2 years to sustain bone mineral density. Toward the later stage of life, he advised concluding the treatment with a single dose of zoledronate. However, the suggested treatment regimen may not be optimal for patients with initially low bone mineral density due to the limited effectiveness of estrogen and bisphosphonates in increasing bone mineral density. And many studies have already demonstrated a correlation between post-treatment increases in bone mineral density and a reduction in fracture risk. Therefore, when treating osteoporosis, if possible, we should treat the patient to prevent fracture, and if possible, we should try to increase their bone mineral density as well. So my question is there a treatment for osteoporosis, whether through medications or the sequential utilization of various classes of osteoporosis medications, that can achieve sustained increases in bone density, prevent fracture, and have minimal side effects? So according to our previous multi-center randomized control study, we recruited postmenopausal women or older men who had been received denosumab for at least 2 years. Participants were stratified and allocated into 4 groups, with Group A as the positive control, receiving denosumab for another 2 years. And both Group B and C and D received zoledronate during the first year, and during the second year, Group B shifted back to denosumab, and Group C received another dose of zoledronate, and Group D went on a monitored drug holiday. And here is the flow chart. We could see that the follow-up rate is 92%. And today I will introduce the result of Group B, because Group B received the zoledronate for the first year and then resumed denosumab in the second year. We found that there is a lumbar spine bone mineral density surge during the second year. We call it a catch-up effect following the resumption of the denosumab. A potential explanation for the catch-up effect could be the decrease in serum wrinkle ligand following denosumab discontinuation. In a recent secondary analysis of a randomized control trial, Solin et al. Observed a peak in wrinkle ligand levels 6 months post-denosumab discontinuation. Here. And the serum concentration gradually decreased over a subsequent 6 months, while the actual mechanism remained unknown. And this pattern could account for the enhanced response to denosumab in the second year of Group B compared with Group A regimen. So we already know that there might be a catch-up effect when we resume denosumab after 1 year of zoledronate. And we also know that when we compare denosumab with bisphosphonate, we found that the use of denosumab has a better effect on bone mineral density than bisphosphonate, and is less likely to reach a plateau. However, discontinuing denosumab poses a risk of rebound effect. In real-world practice, patients often face the need to stop the medication due to reasons such as dental treatment or COVID-19 or anywhere, presenting continuous treatment with denosumab a difficult strategy. So based on the results of our previous randomized control trial and the characteristics of different medications, we have formulated a treatment approach. This method involves the initiating treatment with denosumab as a foundational therapy to improve bone density. After 2 years of treatment, we propose switching to zoledronate for 1 year to mitigate the rebound effect following cessation of denosumab. And then we repeat this circle until the end. So we call this study denosumab sequential therapy 2. We enroll postmenopausal women or elderly men who had been on denosumab treatment for 2 or 2.5 years. Participants were stratified and assigned to 2 groups. Group A, as the positive control, received continuous denosumab for 7 years, and Group B received 1 year of zoledronate, then shipped back to denosumab for 2 years, then another zoledronate, then shipped back to denosumab for 2 years. And we maintained the cyclic pattern till 7 years. And every group we recruit 30 patients in each group, and we measure the bone turnover marker, including CTS and P1NP every 6 months, and also measure the bone mineral density every year. So this is our initial result. These figures illustrate the percentage change in bone turnover markers. Regarding bone turnover markers in Group A, it was observed that throughout 3 years of continuous denosumab treatment, both CTS, the bone resorption marker, and P1NP, the bone formation marker, remained stable because they all used a strong anti-resorptive drugs, the denosumab. However, in Group B, concerning the bone turnover markers in Group B, transitioning to zoledronate resulted in approximately a 20% increase in CTX and about 60% increase in P1NP. So there is a substantial elevation exceeding 60% in P1NP. And upon resuming denosumab, when we resume denosumab here, both CTS and P1NP experience a 20% decrease below the baseline. So they come back again 20% below the baseline. And then when we resume, give the denosumab again in the second year, the bone turnover marker became stable and then returned to baseline. So it's interesting here, there is a potential anabolic window emerges between the lines representing P1NP and CTX during this sequential treatment. The phenomenon might be attributed to a substantial activation of osteoclast precursors after stopping denosumab and followed by osteoblast activation due to a coupling effect. However, as osteoclasts digest zoledronate on bone surface, they undergo apoptosis and to inhibit the bone resorption. But maybe there are also some bone formation occur here. So the total hip bone mineral density steadily increased in Group A over the 3 years period, just as previous data show in long-term denosumab treatment. In contrast, Group B experienced a stable bone mineral density after treatment with zoledronate, and then there is also a catch-up effect. So there is a rapid increase in bone mineral density after resuming denosumab, so we call it catch-up effect. After 3 years of treatment, the total hip bone mineral density in both groups became comparable. And the pattern observed in spine bone mineral density mirrored that of total hip bone mineral density, where there was a laser increment in Group B during the 3rd year. And it is important to note that the number of participants who completed the 3-year follow-up remained limited. The study is still ongoing. And the pattern observed in femoral neck bone mineral density differs slightly from the previous 2 sites. The increase in femoral neck bone mineral density is more pronounced in Group B compared to Group A. This findings is particularly interesting as enhancing femoral neck bone mineral density is recognized as a challenging aspect across various medications. So there are several potential benefits arise from employing this cyclic treatment. After discontinuing denosumab, there is a synchronized differentiation of osteoclast precursor and recycled osteoclast. So, and this phenomenon was leading to large bone resorption and became more pronounced after several years of denosumab treatment. In a post-hoc analysis of our previous study, a significant difference in lumbar spine bone mineral density was noted in patients who with prior denosumab treatment. We could see here, if the patient received denosumab treatment for 2 years or less than 2.5 years, after transition from denosumab to zoledronate, their bone mineral density remains stable across 1 year. However, if they received denosumab for more than 3 years and then went into our clinical trial, after transition, their bone mineral density would decrease a lot to 4%. Previous studies on the sequential treatment of denosumab with zoledronate reveal conflicting results, where a study in Greece showed an increase in lumbar spine bone mineral density after 1 year of drug transition. A study in Denmark demonstrated a decrease in bone mineral density after the same duration of drug transition. So, given the difference in prior denosumab treatment duration, while the denosumab treatment duration was less in Greece and longer in Denmark. And in Ferrari's study, patients who received denosumab treatment for an average of 4.9 years were subsequently treated with zoledronate following strict readministration criteria. Within the first year, most patients receive at least 2 doses of zoledronate, with some requiring up to 5 doses due to specific criteria. Despite this, significant bone loss of 4% to 8% in the lumbar spine was still observed among groups. So this is also the reason that why we design our treatment protocol as 2 years denosumab, then 1 year zoledronate. So the other benefit of our treatment protocol is that we could increase enhancing the treatment flexibility. If the treatment goals are achieved, such as we setting the goal of treatment of osteoporosis for the patient with a T-score larger than -2.5 or -2.0, a drug holiday may be considered after completing zoledronate for bone density consolidation. This therapeutic break may alleviate concerns regarding rare side effects such as osteonecrosis of jaw or a typical femur fracture. Adopting a cyclic treatment approach, intermittent use of denosumab for shorter duration, only 2 years, minimize the concern of rebound effect. Another potential benefit is that in the course of osteoporosis treatment with anti-resorptive agents such as strong anti-resorptive agents, denosumab or zoledronate or some bisphosphonate, there are many micro damage may accumulate in our bone. This is the micro damage, and it would cause our osteocyte to secrete rancoligand to call osteoclast to repair it. But during the treatment, all these will be inhibited, especially in the denosumab, then cause many micro damage accumulate in our bone. And this accumulation potentially leading to conditions like osteonecrosis of jaw or typical femur fracture. But on the other hand, after discontinuation of denosumab, this unopposed rancoligand here, many rancoligand here, will also cause the osteoclast to activation and cause to repair the micro damage, but also cause bone resorption and loss of bone mineral density. So our cyclic treatment protocol, there is the anabolic window here, and we could release osteoclast precursor every 2 years to repair our micro damage and to cause some anabolic effect. So I think this cyclic treatment protocol is beneficial for our bone. Our preliminary findings indicate that cyclic treatment with denosumab and zoledronate at the very least demonstrate comparable bone mineral density performance to continuous denosumab with fewer potential side effects or concerns during long-term treatment. However, whether the bone mineral density can continue to increase steadily in the future requires a more extended time of follow-up, and also the fracture risk. And the final advantage is that the use of long-dosing drugs, either zoledronate or denosumab, promotes better drug adherence. According to our previous study, during the first year, patients using parenteral osteoporosis medication have better adherence compared to those with using oral medications. So the parenteral one is the color is orange, and the oral one is blue. And even in the second year and third years, the adherence is nearly double than the oral form. So our protocol composed of 2 long-dosing drugs, including denosumab and zoledronate. We think that it will improve whether in the real-world practice in the future, it will cause a better drug adherence. There are also several potential drawbacks to consider. Firstly, although we anticipated that our cyclic treatment could periodically repair micro damage, the presence of residual bisphosphonate within the bone might potentially increase the risk of osteonecrosis of jaw or a typical femur fracture. Secondly, there is a potential for increased fracture risk due to the fluctuation in CTX and P1NP. However, no elevated fracture risk has been observed currently in our study. We could see that in Group A, there are 3 people suffer from low energy fracture and only 1 in Group B. So currently, there is no evidence that when changing to Group B, that it would cause more fracture risk. And finally, we could still found in real-world practice or in our clinical practice, the patients there is still issues of medication discontinuation during the treatment period. Nevertheless, even in such cases, the cyclic treatment condition appears to better control the rebound effect. Additionally, previous literature has suggested that in individuals who have previously used bisphosphonates and then discontinued denosumab had a low risk of fracture and experienced less bone mineral density loss. So my conclusions are the sequential treatment with denosumab and zoledronate results in continuous increase in bone mineral density. Other benefits include a potential anabolic effect and periodic repair of micro damage. These benefits position this sequential or cyclic treatment protocol as a lifelong option for treating osteoporosis. And longer follow-up and studies focused on fracture are needed in the future. Thank you for your attention. We look forward to welcoming you to Union County in the future. Thank you.
Thanks, Dr. Fu. This is a very new concept.